pick up from where Dr. Muhoozi left from. So as you've rightly said, ours is a very super specialized practice, and obviously it was very daunting to us to try and do this. So some of the things that were key to us were, obviously we wanted a success, we wanted a good success rate, and we also wanted to, we did not want to scare the population. Imagine you go for your operating heart surgeries, already there are a couple of people who don't believe that's possible in Uganda, and then we say we're going to do it in Mbarara, and then we come back and say we did 5, 4 went, but we didn't want. So we were trying not to have that. So it took us quite a bit of planning to you know, decide on how we were going to do this. But I think one of the things that we were very insistent on was we had to set up sort of standards or guidelines, and we were very stringent about this. So we had certain criteria for which facilities we were going to. We also had very stringent criteria regarding that sort of patients who were going to operate, given how complex this was. And yes, we were doing closed. We started by go with closed heart surgeries because obviously these do not require as much manpower perioperatively as open heart surgeries. So we zeroed in on patent ductus arteriosus. It is, okay, I will not get into that. So we zeroed in on PDAs, and these are, when we operate them at the Heart Institute, we do it invasively and non-invasively. For the surgical ones, they go home within maybe 2 to 3 days, which is a good thing, and their procedures last about 1 to 2 hours. So they're pretty short, and if handled the right way, they're good to go home within 2 to 3 days. So we thought, let's start with this. And we may say, okay, it's a minor surgery, but then the impact is really high. When we go out to these facilities, we've gotten 16-year-olds who are stunted because they have a PDA. It's something we close in an hour, okay? So we obviously had to decide on what procedure we were going to do, one. Next, which facilities are we going to? As Dr. Muhoozi has alluded, we wanted to ensure continuity of care for our patients, but also to cut time, we wanted to have patient selection done before we got there. So obviously we decided, okay, we have to have a resident pediatric cardiologist in this facility. So that is one of our criteria. And then the other thing was that we had to engage a multidisciplinary team. So this involved surgeons, it involved anesthesiologists, it involved critical care nurses and operating room nurses, and then the administrators. And importantly for us, it involved communication people / media, because these helped us to reach out to policymakers. We needed to get the word out about what we were doing. Then people were encouraged to come to us, but also interestingly, what we've seen as we've gone ahead, which I think we'll hopefully get a chance to talk about utilizing social media and the media. When we put out the stories of what we are doing, we actually have people on social media now come up and want to contribute to what we are doing. And this is in terms of funding or even just buying a plate of food for some of the patients we are working on. So we had to leverage all those things to ensure our success. And they may seem like minor things, but we wanted to get this right, and so we're very insistent on this. And again, it's a very collaborative approach, and that's the stance that we've taken, and I'm glad to say that it's working for us, and it's a good place to learn from. The other thing we are always particular about when we go to a facility is we want the local staff to be involved with us. So we are very insistent on that, and this is right from the administration. So before we get there, we have lists of who are going to work with us, who are the surgeons working with us from the hospital, because we want them to take ownership of these. We've seen when foreigners come for our camps, some people even don't enter the room. They say, those are the camp patients. They are the British patients. No, we're working on Ugandans from Mbarara. They're coming to Mbarara Regional Referral. So we're very insistent on the local team sort of taking lead, and we are keen to share skills and grow skills. And I'm happy to say that these camps have, through that insistence on that, we've had opportunities for collaboration. We now have a number of facilities. We had the team from Ginger come to visit our facility to see how they can make their facility better. And we're in talks to have different teams come and train with us at the Institute, because they've seen the advantage and the beauty of what we do and how it impacts on patient care. Thank you.
That sounds really impressive. The question that's going around in my head is how do you pay for it? But I won't ask now, unless it's short.
Yes, so I will keep it short. So initially, when you're starting something, no one exactly believes in it, as Dr. Muhoozi said. So when we started, we also use a lot of we have particular drugs that we use, and we know we are going to facilities that rely on NMS, and we know there are problems with NMS. So the first maybe 2 camps that we did, we were taking things out of our local stock. So we literally came out with lists and carried these things with us. And then we leveraged some of the petty cash that's available at the Institute to buy some of the extra supplies that we needed. So that is how we got this going. I'm happy to say that going forward now, the government is very happy with what we are doing, and these things have been entered into our annual work plan. And so the government has set aside budgets for us to now do this. And we also have external funders, other facilities and organizations that have come in to partner with us. Thank you.
Okay. I guess that's lessons for us in case we want to start something that seems impossible. We might have to take out of our pockets to first show that this is possible, and then people are trying to help you afterwards. So, Dr. Namuwaya, your first camp, what did you walk out of there thinking? Do you have lessons that, are there things that stuck with you from the first camp that you did?
Thank you, Dr. Mary. My first camp, I think what I came out with was preparedness. We will try and prepare and think of the possible outcomes and try and cap them before you even get them. Okay, so you try and say, I may get an arrest. Do I have adrenaline in the hospital? Do I have maybe KCL in case I need it? So when I was still in Mulago, I had a bag, a small bag that I would stock up on drugs. I would go to the ICU, and most of the time you find these drugs are in the ICU. I'm still going to use them on patients within the hospital. So it's not like I am taking them out and working on a private patient. They're still for the patients within the hospital.
Reappropriating.
Thank you.
Resources.
So I had that bag, and it had almost all emergency drugs that I would need, almost all. So it's a bag I never leave when I go for a camp. I have that bag with me. I have an airway bag with me. My airway bag has almost everything. Almost everything. OPAs, LMAs, laryngoscopes, everything that I need. Almost everything I have in that airway bag. And it's something that I will still not leave behind. But then the other thing that I take with me is patient selection. So most of the time for camps, when let's say residents are coming by or people that are training in fellowships, they want to do some of these patients. Maybe at their training centers, these things are not available. But you find that at the camps in the rural areas, there are so many cases that can be done, and you have not experienced it. So they want to do the complex cases. However, after working on these patients, you're leaving these patients for the local team. Will the local team be able to take care of these people? So in the last camp, we had the plastics fellows wanting to do a flap for a patient. And when they came and asked me, I'm like, I don't think we should do a flap for that patient. The question they asked me, are you a plastic surgeon? I'm like, no, I'm not a plastic surgeon. But from experience, I think the flaps are going to fail because the patient is not optimized, they are malnourished, so I don't think they are going to take. So they're like, okay, you're not a plastic surgeon, as we think it's going to take. I'm like, okay, you can. But what I'm saying is just debride and leave the local team to heal these wounds. There were sores. So they wanted to flap some muscles there, cover them up. I'm like, okay. So that patient had a very difficult spinal. Stroke patient, rigid, doing the spinal on the side, so many attempts. We finally give the spinal. So I'm like, okay, you're debriding. I walk out of the room. I go and do other cases. So the student that I had with me comes and tells me, oh, they've gone beyond the debridement. They're actually doing the what? The flap. I'm like, okay. So I leave theater. They were still working. I go to the ICU to review patients. After they come and like, oh, the flap, it was just not holding. So they had to actually revert back. Whatever flap they had put back, now they had to go back. So the man had more wounds than he came with. And they're leaving these patients with surgeons that are on the team. So I think patient selection is one of the best things that you can have, because the outcomes are what matters, and the teams that you're leaving behind. Imagine, like, let's say for the PIDs, the neonates that we worked on, we didn't have a PID surgeon in the regional referral. One of them leaked, okay? So they could have maybe gone in and did a stoma, but the local team most likely was uncomfortable with it. So they didn't go back in. And by the time they were leaking, we had left. So what we leave for the local team also is important. Yeah, that's it.
Maybe I should ask you my next question for you, and then just come through the other speakers. Are there lessons? Is there a way that you have become a different person now as an anesthesiologist, or even during your training, because I think you started doing camps when you were still in training? Are there things that you have learned along the way, apart from what you've said, that have made you different as an anesthesiologist? And is there any advice that you would give someone in training about this kind of thing?
I think, yes. I think there are things that I have learned. The first camp I went to, I was used to isoflurane, sevoflurane, and Tidal. I go and there is none of that. There is halothane. I had never used halothane. There's no halothane in Mulago anywhere. So I'm like, I'm going to do an anesthetic with halothane. Like, okay. So I call some of the people that have used halothane. I'm like, so what do I do? What happens? What should I expect? This. I'm like, okay, I can deal with that. So we worked. Then also the machines that we're using are not the ones in Mulago. The current people in Mulago feel like the machines they have are old, like the ones at casualty, they feel like they're old and all. In my head, I'm like, you should come and visit, let's say, Fort Poto.
It's because they're seeing the Atlan and the Mahindra machines over there.
Fort Poto, Arua, Iganga. Like Dr. Muhoozi said, I went to Iganga and they had no functional anesthesia machine. No, it was not functional, but they were still giving anesthesia for the obstetrics patients. I'm like, so you get a high spinal, what happens? So I'm like, you are clearly supposed to close this theater and say we're not going to work. But politics, like there's the LMNS, like you cannot close the whole theater for district hospital because everyone will be complaining. So the acting MS was an undergrad alumni. So I talked to her and I told her, I feel like you're compromising on safety just because you don't want to appear like the bad person. Close it down. When they ask why we've closed it, we are not safe. Because when the patient dies and it's your license on the line, they'll ask a person of your same cadre and they'll ask them, would you have done this? They'll say no. And that will be the end of you, okay? So when we compromise, we tend to massage the people that these things are available. So anyway, they didn't close it down. It's still, the theater is still functional without a machine. But the other thing it has taught me is, in case I go to a place and I do not know, I've not used the machine before, I'm able to figure it out. Because I have used so many machines, some even don't have names. Like, it's a machine there, and then you look at the manual, it's in Chinese. You're like, where do I start? You're like, you know what? As long as I can do a 2-bag test, that means I can ventilate. That is it. We are going to work. So I think it opens you up to say that nothing is impossible. The people that are here have been using these machines. Yes, they get some complications, but patients walk out of this place also as well. So you can also work in such conditions. Maybe you'll be a little safer with the background knowledge that you have. The other thing I could tell anyone here is, when there's a camp, when there's an opportunity to go and, let's say, impact knowledge to the people out there, please go. It's very fulfilling to hear what they go through. The local team in Arua didn't work with us. Why? They are 3 anesthesia providers for the whole regional referral. Obstetrics still had to go on. So one person works day, one works night, the next day they are off, the other person comes in. They are 3. So they could not even actually come and be with us. Why? Because they had to still run the obstetrics. We're not in that theater. But they cannot get sick off. They cannot, their maternity leave, they call them back. Like, all those things. You don't get an annual leave. When you have an annual leave, you're only 2 people left in the hospital. So when you hear such stories and you're like, okay, you know what? I'm very privileged in where I'm practicing. But I am glad I am impacting some knowledge and making life a lot safer for the people that they are providing the anesthesia for. Yeah, that's it.
Thank you very much. A lot of things there. You're being an advocate for, and trying to encourage people to advocate for things. Well done. Well, now I want to go back to Prof, and I have a few questions that have been coming to my mind. And one of them is, you like numbers. That's something that anyone that knows you knows about you. You like numbers. I don't know if you've always had these numbers while you were going about camps. If you could care to comment about data and how we go about it, like even for us as anesthesia providers. A lot of talks in the morning, everyone's like, oh, you know, there's all these shortages, but we don't really have data in Uganda regarding this. And it's not for lack of having things to write about. But yes, if you could comment about that. And then the other thing is, I'm curious to know, but again, you're probably a different crop, but why did the surgeons suddenly start to consider that it was important to involve anesthesia in the planning? You saw that question coming. But yes, why did it become, suddenly important to involve anesthesia in planning? And then maybe just another one on surgery, and maybe, sort of going forward, this model of camps, should we keep at it? Is it something we should put in a national policy of some sort? And how do you see surgery growing from it?
Thank you very much for those questions. Maybe I'll start with the last one. When we left the West Nile, we had about, when they had screened about 6,000 patients, I sent a message that please stop. But then even when they stopped, people walked in. So we had about maybe 7,000 that come. So we did, the figure you put there, I think there are about 40 more. So there are 2,270. So we didn't operate on about 3,000. We let them go back. And of course, I saw a picture of about 9 that were waylaying the people who were working in theater, waiting for them to. It was about 8:30 p.m. I don't know if that was Yombe. Patients were waiting, and the door was there, and I knew there was only one exit and entry. So I don't know what happened to the people when they. Anyway, so the thing is, then what do you do? You've done the camp, you've left. What about those people who haven't been operated? I was pleased to know that actually about maybe 3 or 5 sites continued with the patients that we didn't operate. So they actually continued, and one team did 15. I think they had never done 15 in a day, so they were celebrating. So they carried the momentum, the energy, and continued. Then I thought to myself, I happen to be the chair of the Department of Surgery, and for a long time I've been pushing that we don't let you go if you haven't done a minimum number of procedures. And I've had a lot of trouble with that. I'm very unpopular because people have stayed a bit more because, doctor, I've done 3 and you're saying 5. Surely 3. And I would say no. So now I've discussed with the principal of the college and a few other people, and we say, but look here, there are so many people who need surgery out there, and the residents here are saying they don't have the numbers. Why don't we put them on the bus? And they go for a week, and another group goes. And we hit 3 birds with one stone or 2? Okay, 3 birds with one stone. Because the politicians will also be happy. So now the sustainability of this, you're talking about policy. Right now, Parliament and the Ministry of Health are convinced that these surgical camps are necessary. So they have promised, I won't tell you that's for the 3rd time, but they have promised that this time there's going to be a vote in the budget to support surgical camps. So that one they have said. So this model of camps, I think it is similar to what the Art Institute people are saying. They have realized that actually this is possible. When we were in the Nkole sub-region, the amount of work that was done, when we worked it out, it was surgery that's done in about 1 year in the region. So that is a backlog you've sorted in 1 week. So, and you're talking about statistics. So when we distill those figures and explain those things, then the minister was trying to say, I think. So we worked out that for every dollar spent, the benefit was $4 if you are to look in money terms only. So I told the Minister of Health that we finished the Nkole camp, but if I was to give you the bill of the patients who operated, the bill, it was going to be 6 billion Uganda shillings. But the actual money we used in kind and in cash was about 1.5. So that is huge impact that is spoken to the fact that now everyone is convinced, I hope everyone, but they're convinced that this model should be carried on. And if the money is available and other resources are available, then some of us will stop running around, running after the food and the rooms, and focus on safety and focus on the things that we should focus on. The first one you asked about numbers. I read a book, and it must have been by, I think, Malcolm Gladwell, or was it Atul Gawande? I don't remember now. That counting is very important in life. We have to count. We have to count. We have to count. If we don't count, we won't be informed. There's a level at which things become so complex that common sense can't work anymore. You need to have counted and looked at the figures and say, this and this and this is equal to that. But definitely we have a challenge of publishing. So we need to encourage ourselves to publish, to respect the work we do, because sometimes we don't publish because we think it is not important. I understand that there are no camps in sub-Saharan Africa that has been as massive as have been done in the past 3 years. There is no other country that has done so much. And therefore, if we don't write about that, how will it be known? Or how will advocacy happen? So those are important things. So we have 3 manuscripts on table that we want to push through. They are almost ready. Massive, intensive surgical camps in sub-Saharan Africa, and many other bits in there. So we need to count, we need to be brave and publish. There are many problems with publishing or trying to publish. You write, and then you've done so much work, you know they're going to accept it and even give you a medal, and then they reject it. And then you say, never again am I going to take myself through this embarrassment. And but don't take it personally. If you put it in and they reject it, it is not about you. Actually, it's their problem. They have missed your work. So go elsewhere. As long as they give you comments, you improve it and push it in. Actually, the only paper I've ever published, and I almost had no comments, apart from, please check if your name is spelled correctly, my name, if I've written it correctly. That was my very first paper I published. That is 167 papers ago. But the subsequent ones were all hard work. They reject, you write, you know. So we have to develop a thick skin and write. Why did we think it was important to? maybe as a group, surgeons will become more mature. More aware of what's responsible for good outcomes. Many years ago, we used to do surgery and the outcomes were not great. Because we even didn't have anesthesia providers, there were not enough. And as a surgeon, you were in charge of everything. And the outcomes are not great. And now, as we've noticed that as anesthesia has become more and more specialized, more people, the outcomes are getting better. You can even dare do more invasive and complicated procedures, and the outcomes are great. We used to do WIPOs without ICU, so I won't tell you what used to happen. I won't tell you what used to happen. But now, you do WIPOs and you go and people are still alive, eh? So there's your answer.
Prof. Well, we are doing something good there. So I think Dr. Muhoozi will just slide into here perfectly. And the question that I have is, as Heart Institute, this is a super specialized work that you're doing. Do you see that this is something that other super specialized services could adopt? And one of the ones that I think about off the top of my head is, for example, the Cancer Institute. And if that is something that can be done, you know, are there some thoughts, do you have some thoughts on how we can scale up this kind of work, especially for super specialized services?
Thank you very much. I think actually the Cancer Institute beat us to it. They already have regional cancer centers, but I think they are more of clinical-based, non-interventional based, screening, diagnosis, and management of things which can be managed. But from the interventional point of view, yes, I think this is something that can give short-term solutions to the patient, because at the end of the day, the single individual we owe a lot to, leave alone the systems, leave alone what we want to accomplish, the single individual we owe our work is the patient that we have attended. So these camps, do they offer those solutions to these patients? The patients that Prof and I so worked on in Western Nile, yes, it was impactful. The first time we went to Mbarara, we worked, I think, close to 11 patients. When we went to Jinja, we did close to 12. Lila had some challenges. We did few patients, and we can explain that because Jinja and Mbarara have got a resident pediatric cardiologist who stays there, who screens, who follows up, who knows. One of the sad stories, Dora in Mbarara, when we first started this whole project, she had screened about 21 patients. By the time we went to operate, 7 patients on her list had died. So those we owe services to. Those that we actually give services to, they're impactful. Now, as we grow, we have taken it a little bit up. We started by saying that, this new center, let's do 1 case a day, and we see then the following day, say, let's do 2 in the morning, 2 in the afternoon. But the last time, Dr. Ayupo allowed us and said, you run like how you want. We did 3 patients in the morning and 3 in the afternoon. I think it was the time we were with Bruno here, Dr. Bruno. But then at the end of the day, it is a solution to a resource-constrained environment. Some of these services are costly. The cost of closed heart surgeries at the Heart Institute, if one is paying out of pocket, is around 3.6 million Uganda shillings. When we are doing it at the regional referral hospital, it is free. Money has been put in drugs, and you have well-wishers contributing to that. So you're actually giving this service free of charge. Now, other specialized services, can they adopt that? I think yes. And at the end of the day, all of us in our respective places of practice or professions, if we actually agitate and shake the hive more, things will start to work out. Our policymakers and I think our leaders at a certain stage, frankly speaking, is that they have taken us and the Ugandan for granted. Not a political statement, but in a way that a population which does not know what to expect, the accountability you need from your elected or policy makers, then the less you will get out. So if we are all aware and we agitate and we say, this can be done in Mbarara, and have demonstrated that it can be done. Now what I need you to do is train or open up a human resource structure that can support an anesthesiologist there, a cardiac surgeon there, a cardiologist there, and critical care nurses, and they are there in the system because you have an institution which is training them, but you can't absorb them into the workforce. So if we agitate more, we shall get things moving and working. But at the end of the day, as you say, that respective people have got to put in and say, I don't think that you have to put in, but wherever each one of us are serving, you do something, and then from that you get learning experiences. I will furthermore add that when we did that to the regional referral hospitals, we picked up lessons on which we said, now look, this has been done in the Uganda Heart Institute, and now we have taken it to a regional referral hospitals, and all the patients we have worked on have done well. So why can't we start exploring if we can have a center within Kampala that can actually do these procedures? And it is something that we are interested, and we are looking at possibilities of where this can be done. But it is something which can come out from the neurosurgery team, from the urology team, that at the end of the day, if you have a university with a medical school, but then is teaching things which they are not academically going to practice on, then it is a deficient program. And then that is an avenue that the university would also collaborate with us, with the other practitioners, and say, by the way, interested to see how this can come here. This is one way, how synergy through advocacy, institution practitioners, and then the patient groups. Hope I have answered the question zigzag in a manner that brings the point home. Thank you.
Yes, it does. Thank you so much. And I think Dr. Kiwanuka can just slide in there and tell us your thoughts on how you think all these kinds of camps can impact anesthesia in the country.
Thank you very much for that question. This morning I talked about people being aware. And while Dr. Sophia was talking, I remembered the story about the man who was complaining to God that he had no shoes until he saw one who had no feet. You can't tell the picture of anesthesia in this country until you move out of your comfort zone. There are so many anesthesia providers in this country who are not even able to make it here because they work alone. They can't have leave. They can't get sick. They basically just abscond from duty to just get a day off. And then there are repercussions. Why? They are immediate supervisors at the district. So they'll never attend any conference until we carry ourselves from wherever we are and go and see how dire the situation is. When we get there, we shall know what to advocate for. And that is the story that anesthesia has got to change. It is life-changing for you to get to that health center and you find someone who cannot intubate, but they're serving a population of over 200,000 people. You get there and you learn that the machine died so many years back. I went to a constituency, I think it's in Rwanda, and we found the theater closed. Why? The roof collapsed. Sorry, the ceiling collapsed. The MP is one of the most powerful ministers in this country. They had not done any operation in 5 years. The last operation was an I&D, 5 years prior. Five years prior. The health center did not have a refrigerator. If any patient needed transfusion, they got referred to Itojo. And guess what? The anesthesia attendant in that particular district, the anesthesia attendant had been moved from a center that was functioning and been moved to this unit without a functional theater. I had the opportunity to go to the other place where I had been moved from. And again, luck that it is, we found this woman who was waiting for 250,000 shillings to fuel an ambulance to go to get referred. She had obstructed labor. She had been waiting for a whole night. Again, the skill set is there, and you've got to do something. Now, in this particular place, they do the ketamine thing. Okay? Mix the ketamine, the theater attendant is the one who keeps pushing. Okay? My fancy idea of that monitor where you decide that you'll have a BP reading every 2 minutes didn't exist. I started preparing my drugs, and they said, "You are preparing so many drugs." They somehow had a spinal needle, but they didn't have the heavy bupivacaine. The ambu bag was part of a project for circumcision. We had to pick it. The adrenaline wasn't in theater, the ephedrine wasn't in theater, it was part of the circumcision program. They had to bring them in order for us to conduct this. And thank God, it was extremely unsafe to do any GA. Because I don't think I've not done a GA for a pregnant woman without intubation. Intubation was out of the picture. Then they bring me the bupivacaine, isobaric, but preservative-free. I've never been so grateful to God. We did it, okay? They were shocked I used so many drugs. The patient came out much safer. So, if I don't have that picture, how do I go to the district leadership or whoever it may be to start discussing anesthesia services. If you have any role or any inkling or any nudge to head anything in the healthcare system, you've got to go out and see where the foot soldiers are. And it is a dire situation. We need to go out there and be familiar. On another note, we've been involved in a number of pediatric hernia camps. And at some point, well, my residents go and do these things. They get involved in the entire planning. We select the patients very, very carefully. And guess what? I've seen leadership skills come out. And these are things that make a very big difference, even to the trainee, and later on, these are skills that we get to use. Thank you.
Thank you very much. Israel is going to throw me off the stage, but I want to ask Dr. Ayupo, very briefly, if you could paint the picture of what surgical camps should look like or would look like going forward, what would that look like?
Thank you very much, Dr. Mary. I think I will start by saying that in order to paint this picture, we have to have a vision for surgical camps in the country in the future. And for me, what I envision is a country with equitable access to healthcare, irrespective of where you are in this country, right? And so in that case, we would not need surgical camps. But we are cognizant of the fact that in order to get to that place, we are going to have to take certain steps. And I think surgical camps are a very necessary step towards achieving that goal of equitable access. And I think we've been talking about surgical camps generally, but I would like to emphasize in-country surgical camps. We need to move away from the white people coming here to do things, or the non-Ugandan people coming here to run these camps. Because before, when it was a camp, it was because we had foreigners coming in. But we are a team here that's doing this with Ugandans, with you, people in this audience, right? So we need in-country surgical camps for the variety of reasons that we've explained here. So I just want to highlight a couple of things that, yes, much as we're working towards that, to ensure success of these camps, there are a couple of things we can do. One is to leverage the available human resource in whichever facility you're going to, as well as the human resource that you have to volunteer for those camps, right? So do not say maybe, for us, for example, we need cardiac anesthesiologists to do this, right? And we also need specialized ICU nurses, cardiac ICU nurses to do this. But we are taking our teams to work with the people there and training them to do the basics. So we need to leverage that. Also, we need to leverage various sources of funding. It doesn't always have to be the government. We need to look at others, NGOs and individuals like you and I. 50,000 put together, it adds up to something, right? And then today I like that we've had talks on policy. A lot of us think, for me, I'm clinical and I'm going to stay there. But you're only clinical because there's someone up there making these decisions for you. We cannot run away from the politics. We cannot run away from the policy. And how are we going to start engaging in that? It's by showing them what we are doing. When we expose them to what we are doing, they get an understanding of what we are doing and what we need. But we need to engage in those conversations and start to make those decisions for the teams, right? And let's also, yes, Gen Zs, but let's leverage the power of social media. We're only aware of what ASO did in the previous camps because they were very visible. And as Prof has told us, Parliament is now committing to a vote and all of that. So let's leverage that. It will get us funding, to get human resource, but it will also encourage people to come and work with us and to join us in our vision and in our dream. And as we do all this, Dr. Sophie said something about safety, and I want to emphasize that irrespective of what we are doing, they did 2,000-something patients, but let's not compromise on safety. Just because it's a camp and we are going to do big numbers, let's not compromise on safety. We had to take an anesthesia machine because I was not going to put anyone's 5-kilogram baby on a machine that is just in Chinese with a minimum tidal volume of 300. I'm not going to do that. So we have to emphasize safety first, because at the end of the day, as Dr. Muhoozi said, we are doing this for the patients and no one else. Thank you.
All right, can we give a much better hand clap to our panelists? Thank you so much for sharing your experiences. To our dear friends, the surgeons, thank you for showing love to us and coming out. Professor Galukande is almost a staple at our conferences, and he always comes. So thank you for that. And thank you, Dr. Muhoozi, as well, and the rest. I think it's only befitting if we have a photograph with our panelists.